Hello everyone, welcome back to another session in dentistry and more. Today's session is about various cysts of the jaws. So this session is about the definition of cyst, the parts and stages of cyst formation, then its classification, and the details about lesions with regard to pathogenesis, clinical features, radiographic features, histopathology, differential diagnosis, and management. So the word cyst is derived from a Greek word that is kystis, which means bladder or pouch. So we know the cyst looks like a bladder or a pouch with a proper encapsulation or a epithelial lining, and this is the second most common pathological radiolucency in the jaw. So we have many definitions for cyst. The most commonly accepted is the Kramer one. It is a pathological cavity having fluid, semi-fluid or gaseous contents, and which is not created by accumulation of pus and is often encapsulated or lined by epithelium. So a cyst will be always with encapsulation or a epithelial lining. So this part is a crucial part of a cyst, which has encapsulation or epithelial lining. So these are the parts of cyst, which has lumen surrounding epithelium and further surrounded by a connective tissue capsule. So epithelium could be stratified squamous epithelium or pseudo stratified columnar, and the capsule consists of fibroblast, fibrocyte, collagen, elastin and other cellular components. So a cyst develops when the stimulation happens, then it leads to the proliferation, that is the multiplication, then there will be the arrangement of cells with the creation of lumen inside. So the final cyst will be a peripherally arranged cells with a lumen at the middle of the cells, aggregation of cells. Theories of cyst enlargement, which was summarized by Malcolm Harris in 1975, focusing on three concepts, that is mural growth, hydrostatic enlargement and bone resorbing factors. The mural growth were focusing on peripheral cell division and accumulation of cellular content, hydrostatic enlargement on secretion, transduction and exudation, and bone resorbing factors on osteoclastic activity. So let's see the classification of cyst. So Robinson has classified as odontogenic and non-odontogenic. So in odontogenic we have periodontal, radicular, lateral, residual, dentigerous and primordial cysts, whereas non-odontogenic, that is non-tooth related tissues, this is tooth related tissues. So non-odontogenic tissues we have median cyst, incisive canal cyst and globulomaxillary cyst. In another classification given by WHO, it is based on the developmental and inflammatory. So developmental we have odontogenic and non-odontogenic, just like what we have seen. Some additional classification: the alveolar cyst of infants, gingival cyst of adults, and we have non-odontogenic mid-palatal cyst of infants. In inflammatory we have follicular cyst, radicular cyst and lateral periodontal cyst. So shear classification is a very simple one: the epithelial lined and non-epithelial lined. So in epithelial we have development and inflammatory, development, odontogenic and non-odontogenic. So cysts of maxillary antrum are benign mucosal cyst or surgical ciliated cyst of maxilla, and cyst of soft tissues of mouth, face and neck. All these cysts will coming under this category. Now let's begin with OKC or odontogenic keratocyst. So odontogenic keratocyst, which has lots of synonyms such as dermoid cyst, cholesteatoma, primordial cyst, keratocystoma. So OKC was named by Philipson in 1956. So it is arising from dental lamina or its remnants by proliferation of basal cells of oral epithelium. In clinical features, its incidence is 3 to 11% of all odontogenic cysts, and it has a bimodal peak, that is third and sixth decade, and the predilection is more in males, and it is commonly seen in angle and ascending ramus of mandible, and it has got symptoms such as pathological fracture, pain, swelling, discharge, paresthesia of lower lip or teeth because of the nerve involvement, and also since the cyst becomes enlarged and resorbs the surrounding bones, so there will be displacement of teeth and anterior posterior expansion. So when we take aspirate, we get a odorless, creamy or cheesy content. In radiographic features, we see a round or oval, well corticated radiolucency with a large expansile and scalloped or multilocular lesion, which displays unerupted, impacted teeth and also the inferior alveolar canal. So there will be perforation of the cortex, and the epicenter is above the inferior alveolar canal where the cyst origins, and it grows along the internal aspect of jaw with minimal expansion. So I can see a cyst over here. Okay, so it expands along the internal aspect of jaw with a minimal expansion. So internal aspect of jaw with minimal expansion. You can see this. Okay. So it has a few radiological types such as follicular cyst, which surrounds the crown of an unerupted tooth and is attached to the neck of the tooth, which is known as denticyst. Envelopmental type, which may envelop an adjacent impacted tooth. Replacement type, which form in place of normal teeth. Extraneous type, which is in the ascending ramus away from the tooth, and collateral type is adjacent to root of tooth, similar to our lateral periodontal cyst. So in histologic features, you can see the satellite cyst, which is a unique feature, and the tombstone appearance of the basal cells. The basal cell has tombstone appearance. Then we can see a separation of lining from the capsule, then the big lumen and the parakeratinized epithelium. So based on the histology, we have two types. That is, one is parakeratinized, it is the major one, which has aggressive and high rate of recurrence, whereas the orthokeratinized one, which produces only orthokeratin, which is associated with dentigerous cyst around third molar, which is less aggressive and which is not associated with nevoid basal cell carcinoma syndrome. So there are few syndromes where the OKC is reported, such as NBCCS, Marfan syndrome, Ehlers-Danlos syndrome and Noonan syndrome. So we have differential diagnosis. One is ameloblastoma, the residual cyst, odontogenic myxoma, traumatic bone cyst and the dentigerous cyst. So in management, we need to go for enucleation, massopilization or peripheral ostectomy, osseous resection, chemical cauterization, or decompression. The recurrence rate in OKC is comparably high because of the presence of satellite cyst and the thin epithelial lining. It has got intrinsic growth potential and proliferation of basal cell. Okay, so it has proven that it is a neoplastic change. So it has got neoplastic change because the nevoid basal cell carcinoma syndromes reports the presence of OKC. Now we move on to dentigerous cyst. Dentigerous cyst encloses the crown of an unerupted tooth by expansion of its follicle, which is attached to its neck, which is also known as follicular cyst or pericoronal cyst. So Brown and Smith named this cyst as dentigerous cyst, which is two-layered enamel epithelium, that is reduced enamel epithelium. So it was actually covering the newly formed enamel, and it will disintegrate once it erupts into the oral cavity, and it merges with the gingival epithelium, and finally it becomes junctional epithelium. But what happens if it is not disintegrates and if it start collecting fluid between the enamel and this reduced enamel epithelium? This cyst formation happens. So there will be degeneration of stellate reticulum at an early stage of development with associated enamel hypoplasia. So after completion of crown formation by accumulation of fluid between layers of reduced enamel epithelium. So the enamel epithelium will become reduced enamel epithelium when the stellate reticulum collapses and the outer and inner enamel epithelium comes closer. So if there is degeneration of stellate reticulum at very early stage of development with enamel hypoplasia, there will be accumulation of fluid between this reduced enamel epithelium. So extrafollicular type is appears to be envelopmental or follicular odontogenic keratocyst. So how does the cyst expand? So it is by the tooth erupts, the pressure on the impacted follicle, there will be venous stasis and transudation of serum, which increases the hydrostatic pressure, and finally the cyst expands. So in clinical features, it is commonly seen in second to third decades and in males. The common site is mandibular, third molar or maxillary canine areas, also mandibular, premolar and maxillary third molars, and it could also be found associated with supernumerary and odontomes. Symptoms, mostly it is asymptomatic unless it is secondarily infected, and it presents as a slow growing swelling which can cause asymmetry, and the aspiration will be thin watery yellowish fluid with occasional blood. So in radiographic features, there will be unilocular well defined radiolucent lesion with sclerotic border around an unerupted tooth crown. So this is the cyst. Okay, it is around the tooth crown, a radiolucent lesion with sclerotic border. Okay, you can see a sclerotic border which is around the neck of unerupted tooth. Okay, so cortical plate expansion will be there. So usually CBCT or CT will be used to determine the relationship of the cyst to the mandibular canal prior to the surgery. Okay, and MRI investigation also will be done. So we have three radiological variations. One is the central variety where the crown is, this is a central variety. Okay, you can see central variety where the cyst is completely encloses the crown from one side to the other side, where the tooth is centrally located. Where the crown is enveloped symmetrically, here the pressure is applied to crown, pushing it away from its direction of eruption. So the mandibular third molar is a common example, and which is found at the lower border of mandible or ascending ramus. Maxillary canine, which forced into maxillary sinus. Maxillary incisors, which is forced to the floor of nose. Whereas the lateral variety, which is not symmetrical, it is mainly on one side of the tooth, so which results from dilation of follicle on one aspect of crown, okay, not symmetrically on either side, which is commonly seen when an impacted mandibular third molar is partially erupted so that its superior aspect is exposed. So you can see the superior aspect is exposed and its partial eruption. The third one is circumferential type, in which the entire tooth appears to be enveloped by cyst. You can see the entire tooth. Okay, so this is a tooth, the entire tooth. Okay, so the entire tooth is enveloped. This variety be differentiated from envelopmental type of keratocyst. So differential diagnosis, we have hyperplastic follicle, adenomatoid odontogenic tumor, calcifying odontogenic cyst, ameloblastoma, odontogenic keratocyst, and finally the radicular cyst. So just like the first cyst, we have, just like our OKC, okay, we have dentigerous cyst associated with few syndromes like cleidocranial dysplasia, basal cell nevus syndrome, Mortex-Lamy syndrome. Okay, management by enucleation along with the removal of tooth or marsupialization of larger cyst and decompression with orthodontic treatment. The complications could be after an incomplete surgical removal, such as ameloblastoma, this lining epithelium, or from the rest of odontogenic epithelium. Ameloblastoma could develop, or epidermoid carcinoma from the mucoepidermoid carcinoma from lining epithelium from dentigerous cyst, which contains mucus secreting cells. Next we have eruption cyst, which is also known as eruption hematoma, which is nothing but a dentigerous cyst occurring in soft tissues. Occurs when tooth is impeded in its eruption within soft tissues overlying bone. So this is a eruption cyst. Dilation of tooth follicle by accumulation of tissue fluid or blood. Clinical features, it will be well circumscribed, fluctuant, translucent, and commonly seen with mandibular primary incisors and first permanent molars. Transillumination helps to distinguish eruption cyst and eruption hematoma. Okay, cyst and hematoma is different. Cyst and hematoma are entirely different on a microscopic feature. Cyst has a lining, it has a lumen with disintegrated content, whereas hematoma is just a collection of blood. In radiographic features, we get a shadow of soft tissue with expansion of follicular space without any bone involvement, and there will be dilated and open crypt. So we can excise the dome of the cyst, exposing the tooth crown. Differential diagnosis, it could be misdiagnosed as dentigerous cyst or gingival cyst. So gingival cyst of newborn, it is seen in newborn babies mainly due to this dental lamina epithelial remnants. These remnants will become proliferate, and around 15 to 20 weeks it will become a cyst. So it looks like a small white cream colored cyst in newborns up to 3 months at the crest of maxilla and mandible. So it could be misdiagnosed as Epstein-Barr's, which is seen on the mid-palatine raphe, which is derived from entrapped epithelium along the line of fusion, or also it could be Bourne's nodules, that is buccal and lingual aspects of maxillary and mandibular ridges derived from remnants of mucous glands. So treatment is just the removal of contents. The lateral periodontal cyst and botryoid cyst, it is also from reduced enamel epithelium or cell rest of molasses or remnants of dental lamina. Most commonly seen around 50 years, and in males the sites are lateral roots of mandibular canine like premolar and anterior maxilla. Symptoms: gingival swelling with normal overlying mucosa, and the teeth will be mostly vital. So most of the cases when the tooth is associated with cyst, the teeth becomes non-vital, but this is a lateral periodontal cyst, and most of the cases the tooth will be vital. So in radiographic features, it appears as round or oval or teardrop shaped. So you can see a teardrop shape and well circumscribed radiolucent area with a sclerotic margin, which has less than 1 centimeter in diameter, and there is no resorption of adjacent teeth. And unlike many other cysts, there will not be any resorption of adjacent teeth. So it is lined by non-keratinizing layer of squamous or cuboidal epithelium with glycogen rich clear cells. Differential diagnosis: lateral radicular cyst where the tooth will be non-vital. Also lateral dentigerous cyst associated with impacted tooth, or lateral periodontal abscess, gingival cyst, or mental foramen. So mental foramen also misdiagnosed as our lateral periodontal cyst because of its peculiar location and if it is present between the premolars. Management: commonly by surgical excision without extracting the tooth. So gingival cyst of adult, it is uncommon cyst either in free or attached gingiva, soft tissue counterpart of lateral periodontal cyst. It is due to the cystic transformation of dental lamina or glands or rest of serrae, or also from traumatic implantation of surface epithelium. Commonly seen between 50 to 60 years, but in females, and common sites are mandible to canine premolar region. So in symptoms, it is attached gingiva or the interdental papilla of facial aspect. There will be small, soft, painless growth which is dome-like shaped with well circumscribed, which is ranging from less than 1 centimeter in diameter, sometimes blue color. In radiographic features, there will be soft tissue lesion. If enlarges to sufficient size, then there will be faint round shadow which is indicative of superficial bone erosion. In differential diagnosis, lateral periodontal cyst, peripheral giant cell granuloma, traumatic fibroma. Management just by surgical excision. Now we have glandular odontogenic cyst. It is derived from dental lamina and it is name given by Kramer, also known as mucoepidermoid odontogenic cyst, because of the presence of both secretory elements and stratified squamous epithelium. So most common in the 6th decade in male groups, and the site is mandibular anterior, which originate as a small painless swelling which has propensity to grow large and recur. So radiographic features will be cortical boundary which is smooth and scalloped. So you can see the radiographic features, both unilocular and multilocular appearance, expansion of cortical plates with regions of perforation, and also displacement of teeth. Histologic features, this will be superficial layer of epithelium or columnar cuboidal cells, will be hobnail with cilia or filiform extension of cytoplasm. Ameloblastoma, KOT lateral, periodontal cyst or botryoid cyst are the differential diagnosis. We can manage it by local block excision rather than enucleation because of its unpredictable nature of recurrence. Now we have CEOT, that is calcifying epithelial odontogenic cyst. Synonyms are Gorlin cyst, cystic keratinizing tumor, then calcifying ghost cell odontogenic cyst, calcifying cystic odontogenic tumor. So CEOT was first described by Gorlin in 1962, which is unusual and rare lesion with features of cyst and also that of a solid neoplasm. WHO now categorizes this entity as a tumor, not as a cyst. Clinical features around the 2nd decade, which is a bimodal distribution with second peak around 70 years, more common among females. Site is both jaw seen anterior to first molars. Slow growing painless swelling with cortical plate destruction, cystic mass become palpable, and the displacement of adjacent teeth. And it gives a viscous granular fluid on aspiration. So it has few clinical types such as central or intraosseous, which is seen within the bone, occurs centrally within the bone, produces hard bony expansion and may be fairly extensive, whereas the extraosseous or peripheral type, which occurs in the soft tissue overlying the tooth bearing area, which is pink in color, circumscribed elevated mass which is measuring up to 4 cm, and it is associated with odontogenic tumor. Now radiographic features, it is anterior to first molar, cuspids and incisors are involved. So the well defined corticated curve borders with curved cyst like to ill defined irregular shape with completely radiolucent with small foci of calcified material as white flecks or large solid mass. You can see the large solid mass, so which is associated with a tooth and it impedes its eruption. There will be displacement of teeth, then perforation, resorption of roots. Histologic features, there will be thick layer of basal layer of columnar cells and ghost cells become calcified, that is why it has got this name. Dysplastic dentine, which is laid down adjacent to basal layer. Differential diagnosis, dentigerous cyst, AOT, ossifying fibroma, fibrous dysplasia, cementoblastoma, can be managed by enucleation or curettage. Now we have the inflammation cyst or the radicular cyst, which is also known as periapical cyst, apical periodontal cyst or root-end cyst, which is the most common cyst, which arises from epithelial cell rest of molasses in the periodontal ligament, which are stimulated to proliferate and undergo cystic degeneration as a result of inflammation. So in pathogenesis, there will be caries, trauma or periodontal disease which leads to the death of pulp. There will be necrotic debris which stimulate the inflammation. Then apical bone inflammation. There will be formation of granuloma. Then stimulation of epithelial rest of molasses, epithelial proliferation, the segregation of cells and a cyst formation. Finally, the periapical cyst. So the periapical cyst formation, segregation, it becomes a cystic cavity. So there are three phases. First is initiation, where the cyst epithelium derived from the epithelial rest of molasses and the periodontal ligament and bacterial endotoxins are the main initiators of the inflammation. So there will be local changes in the connective tissue. Local changes causes decreased oxygen, increased carbon dioxide and reduced pH. Then the cyst forms by the nutritional deficiency theory, which says that cavity forms within the proliferating mass in an apical granuloma by degeneration and death of cells in the center. So the cells in the center will be deprived of the nutrients and becomes cavity. So the abscess theory postulates proliferating epithelium lines an abscess cavity because of the innate nature of the epithelial cells to cover exposed connective tissue surfaces. Then finally the cyst expansion phase by osmosis and capillary pressure. So in clinical features, we have the most common cyst of the oral cavity, that is 60% of all cysts could be seen in any age and most commonly in males. And most common site is the anterior region of maxilla, and symptoms, it is slowly progressive painless swelling and the tooth will be non-vital. So you can see a non-vital tooth. So you can see the non-vital tooth here and the cyst, the expanded cortical plates. Okay, so this is a symptomatic one. It is associated with non-vital tooth, cortical plate expansion, which will be bony heart and eggshell crackling, and also a soft fluctuant swelling. The aspirate will be straw-colored fluid with low protein levels and large amounts of cholesterol. So the radiographic features, the location is at the apex of a non-vital tooth, that is the epicenter where it originates. You can see the apex. The periphery will be well defined, and if it is secondarily infected, that well defined border will not be there. The outline is usually curved or circular. The internal structure, it is radiolucent, occasionally dystrophic calcification, which may develop in long-standing cyst appearing as sparsely distributed small particulate radioopacity. So if it is affecting the nearby bones, it will cause the resorption and displacement of roots, and the cortical plates will be expanded. It will become curved or circular pattern, and also invagination of the antrum is reported in the case of upper teeth, and it may displace the mandibular nerve canal in an inferior direction. So you can see the periapical cyst. So differential diagnosis could be periapical granuloma, scar or a surgical defect, lateral periodontal cyst, or periapical cemental dysplasia, traumatic bone cyst, or mandibular infected buccal cyst. So management, we need to do RCT. It has a potential to heal without surgical intervention. Sometimes RCT plus periodontal surgery and bone graft, sometimes extraction, curettage and enucleation. So untreated radicular cyst may give rise to ameloblastoma or squamous cell carcinoma. Next we have residual cyst, which is nothing but a cyst that may persist after the extraction of causative tooth, which is more common cause of swelling in edentulous jaw in older person. Now we have non-odontogenic cyst. The first one is nasopalatine duct cyst, which is the most common non-odontogenic cyst, which is 1% of the population is affected, arises from the embryonic remnants of nasopalatine duct or incisive canal duct. It is formed due to trauma, infection, mucus retention, spontaneous cystic degeneration of epithelial remnants, or it could be due to any of the mentioned reason. So clinical features, it develops at any stage, most common in 4th and 5th decade, which shows slight male predilection. Anterior region is affected, like midline of palate and asymptomatic swelling in the anterior palate, drainage through tiny fistula, pain due to secondary infection or pressure on the nerves, and rarely a large cyst produced through and through fluctuant expansion involving anterior palate and labial alveolar mucosa. So radiographic features, we have a well circumscribed radiolucency between the teeth, that is central incisors, in or near the midline anterior maxilla, between an apical to the central incisors, round or oval or inverted pear, inverted pear or heart shaped. You can see a heart shaped with sclerotic border. You can see a sclerotic border. Root resorption and bony expansion are rare. Diameter ranges from 1 to 2.5 centimeter. The histology, epithelial lining, which is highly variable, composed of stratified squamous epithelium or pseudocolumnar epithelium, simple columnar and simple cuboidal, and now blood vessels and mucous, salivary glands with inflammatory infiltrate ranging from mild to severe form. Differential diagnosis as incisive fossa, radicular cyst, dentigerous cyst with mesiodense or median palatal cyst. So we can manage it by surgical enucleation, but treatment indicated only in presence of clinical symptoms and before placement of dentures. The next one is nasolabial cyst. Synonyms are nasoalveolar or clefted cyst, which is a rare development soft tissue cyst occurring in the lip beneath the ala of the nose. So there are two theories which develops from entrapped embryonic epithelium at the junction of medial nasal, lateral nasals and maxillary process, and also it could be arise from remnants of nasolacrimal duct because of their similar location and histology. So it is more common in females at around 4th to 5th decade. In bilateral, 10% of the cases, mostly asymptomatic and painful if secondary infected. It is a fluctuant and obliterates the nasolabial fold. So it arises from soft tissues in most of the cases without any radiographic changes, and it is lined by pseudostratified columnar or cuboidal epithelium, and goblet cells are seen. Acute dento-alveolar abscess, cystic salivary adenoma, nasal furuncle are differential diagnosis, and we can surgically excise it. So this median palatal cyst or alveolar cyst or mandibular and globulomaxillary cyst, they were thought to develop from epithelium entrapped in the process of fusion of embryonic process, but now it is believed that they represent the posterior extension of incisive canal cyst in case of median palatal cyst, and anterior extension in case of median alveolar cyst. Okay, next we have non-epithelial lined pseudocyst, aneurysmal bone cyst, which is described by Jaffe in 1942, which is an uncommon lesion seen in most bones of skeleton. It is an exaggerated, localized, proliferative response to vascular tissue. Okay, so it is a misnomer which does not contain vascular aneurysm and is not a true bony cyst, which is modified by communication with the large blood vessels, or it could be due to the lesions destroyed by hemorrhage or a vascular disturbance. It has 4 stages: osteolytic, growth phase, maturity phase, and healing phase. So it is commonly under 30 years with no sex predilection, and the ankle and ramus of mandible is commonly affected with a history of trauma, firm swellings which may be painful, swelling and malocclusion with enlargement is rapid with limited mouth opening, and recent displacement of teeth which are vital, eggshell crackling but not pulsatile ones. Tissue shows excessive bleeding and blood soaked sponge appearance. In radiographic features, it has peripheral, well defined circular lesions with multilocular one, septa which is seen in between, and ill defined at right angles to the outer expanded border, which gives a soap bubble appearance, expanded cortical plates which displace and the rest of the teeth. We can manage by curettage and partial resection. These are the differential diagnoses: giant cell granuloma, ameloblastoma, cherubism, central hemangioma, odontogenic myxoma, Stephen's bone cyst. Now we have solitary bone cyst, which is also known as traumatic bone cyst or hemorrhagic cyst, which is basically due to the trauma or the faulty calcium metabolism or local disturbance or ischemic necrosis of fatty marrow. It is asymptomatic, seen in first 2 decades of life in males and commonly seen in posterior mandible. The teeth are vital. Aspiration gives a straw colored fluid. Radiographic features: the margin blend with surroundings and scallopy between the roots and radiolucent internal structure without any septa. Differential diagnoses are radiculocyst, CG, fibrous dysplasia, ameloblastoma, and the last one is Stephen bone cyst, which is also known as lingual bone defect or static bone cavity or latent bone cyst. So which is nothing but group of concavities in the lingual surface of the mandible where the depression is lined with an intact outer cortex. The pathogenesis is well defined deep depression, which is associated with growth of salivary gland adjacent to lingual surface of mandible, where the anterior region near apical area of bicuspid, that is a sublingual gland, where it is commonly seen, and it is rarely on the ascending ramus where the parotid gland is there. 5th to 6th decade is highest incidence with male predilection without any symptoms, well defined, round, ovoid or lobulated radiolucency about 1 to 3 cm in size, which is lies below the inferior alveolar canal and anterior to ankle of mandible, with well defined margins with a dense cortical border. So management: no need of treatment unless suspicion of development of neoplasm. So that's all about various cysts of oral cavity. So we have discussed in detail about the most of the cyst in oral cavity, odontogenic and not odontogenic varieties. So I'll come up with a new topic in dentistry and more. Thank you.